Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you for the opportunity. There's a lot of information here, so bear with me. I'll try to muddle through. Some of it is a bit data heavy, but that is sort of the nature of CROI. I'll try to break it down a little bit for you. No disclosures here. I want to put up a couple of disclaimers. There will be some names that we discussed in terms of ART, and so I'll try to do my best to stick to the names that we should be using, which are the generics. And then a couple of other considerations. So we'll talk a little bit about some health disparities, and of course, the data in this presentation are just a kind of limited snapshot of that, and we recognize that there are a lot of things that contribute to those. Racism is sort of chief among those. I'll also add that I think we try to do our best to not be binary with respect to gender, but a lot of the presentations that we hear and CDC data still have touches of that there, so I'll try as best I can to differentiate when there was specificity about gender in some of the studies versus, just saying male versus female. So bear with me on that. Okay, so let's jump in. Cabotegravir. So there's a lot talked about in CROI with cabotegravir, and so I'll touch a little bit about PK data with missed doses, something called the LEVI syndrome that someone brought up, and then a little bit of a mixed bag before we move on to the next topic. So first, starting with HPTN 084, I think many of you are familiar with this study. It's probably been discussed here many times, but just to remind you, it's an ongoing phase 2b/3 randomized double-blind trial that's comparing long-acting injectable cabotegravir to daily oral FTDF for HIV prevention, and this is in persons assigned female at birth who are at risk of acquiring HIV. So most of the people in the study self-identified as cis women. So just to remind you, this was basically an oral lead-in of 5 weeks with cabotegravir, followed by 2 doses that were given 4 weeks apart, and then people switched to every 8 weeks. So the purpose of this analysis was sort of looking at people who had delayed cabotegravir injections, because this study happened during the COVID pandemic. So operational disruptions as well as just people's lives, they weren't able to get there on time. So among those people who were randomized to cabotegravir during the blinded period, they looked at people who had at least one delay, and they categorized them into 2 groups. So people who had a type 1 delay, where basically their second injection took place 8 to 14 weeks after the first injection, and then type 2 delays, any subsequent injection that took place 12 to 18 weeks after the prior dose. And so they broke those down into kind of groups based on the number of weeks that they went between injections on the right. There's a lot of words here, but I'll kind of tell you what the high points are. So 194 participants, or 12% of people, had at least one delayed injection in the study. It's a total of 224 delays. And I'm showing you here on the right side the type 1 delays, so people who missed at least a dose between their first and second injection. So when they looked at cabotegravir trough levels in the blood, I'm showing you here kind of 8 to 10 weeks, people who missed those. There was 11 of those versus 4 for 10 to 12 and 4 for 12 to 14. And draw your eye to these sort of blue rows here. And so this is levels in the blood that are over 4 to 8 times, that acronym stands for protein adjusted inhibitory concentration. So basically the level that we think is high enough to be therapeutic. You can see that 100% of people who went 8 to 10 weeks stayed in that range versus 75% at 10 to 12 weeks. And then when you get to the 12 to 14 week mark, it really dropped off. So 75% of people dropped below the cutoff that we think is therapeutic. And then when we sort of look further out in time, so up to 18 weeks or 4.5 months after the second injection, you can see that over 85% of people maintained therapeutic cabotegravir levels. Again, the same sort of blue rows here. More people that were in these groups, so kind of went longer between those injections. And what the authors did note is that people who had a BMI less than 26, which was the median for the cohort, were more likely to maintain these levels at 8 times above that threshold. There was one woman who had a breakthrough infection, but she had essentially 3 delayed injections out of 9, and her level was below that 4 times cutoff when she was diagnosed with HIV. So they looked at factors that were associated with having a favorable PK profile, both after the first injection and when they were in the every 2-month injection phase. And so the take home here is that basically after you've had your first injection, they saw that in women that the trough levels were about 30% lower than in men. And then they were about 30% lower as well for people who had a BMI above 30. And then once you get into that kind of steady state phase where people are in the 2-month injection period and they've had at least 6 of those, you can see that it kind of flips where there's actually accumulation in women. So they have a trough levels that are about 32% higher. And then people who have BMI above 30, the trough levels are actually a little bit lower, so less by about 5%. So what they concluded from this is that despite having delayed injections of up to 6 weeks, which would be 12 to 14 weeks between injections, that CAB-LA levels remained therapeutic. So 90+% of patients, they saw that. And maybe they are saying, there could be an up to 6-week kind of forgiveness period that could be feasible for people assigned female at birth who are receiving CAB-LA for PrEP. Although, I think everybody's very nervous about that and sort of putting that out there, but at least the PK data kind of support that. And so one thing that the author said is, potentially in the future, it may be plausible that you could move to a quarterly or every 3-month dosing approach. But of course, that needs to be studied. That was not the point of this study. They were just looking at women who happened to receive it this way with delayed injections. It wasn't a set Q3 month schedule, but maybe that's something that could happen in the future. So stay tuned. I thought that was interesting, at least to sort of look at real world data when people can't come in on time. So Sue Eshelman talked about this syndrome called LEVI syndrome, which is long-acting early viral inhibition. And so in the setting of injectable cabotegravir, I think we all know that viral suppression happens and that there's delayed and decreased antibody formation, which can lead to false negative testing. And so that's what's depicted here on the right in this graph that you've probably seen before, that this person basically, there was a 9-month span between retrospectively kind of when they looked back and saw probably that's when they acquired HIV. The qualitative RNA was reactive, but the other testing was negative, and the viral load was only 6, which is super low, nothing that we would ever be able to determine clinically, compared to when all of the testing was positive, 9 months later, they already had integrase resistance. So in HPTN 083, they looked at the 6 people who had HIV or acquired HIV despite having on-time injections and noted that, 50% of these people detection was delayed for the reasons that we just talked about. So she wanted to point out, just kind of from a clinical standpoint, how acute HIV differs from this syndrome called LEVI. So I'm not going to go over what's on the left because I think all of you know what acute HIV looks like, but really wanting to bring your attention to this new syndrome. And so the main things are that viral replication in this syndrome can be kind of smoldering and people may have minimal or no symptoms at all. And so the way that this would be detected is by an ultra-sensitive RNA assay. And I don't know, what all of your viral load cutoffs are, but I know here there's no way we would be able to say, a person had a viral load of 6 or 10 or 15. So that makes it challenging, right? Because I think that's sort of limited to research settings. There can be assay reversion for many test types. So meaning someone had maybe an initial indeterminate or positive, and then that went back to negative and can kind of flip-flop, and that makes it tough to differentiate. And this can really occur for months until people have viral breakthrough or issues develop like drug resistance. And so that can emerge, of course, when the viral load is quite low. And so that's a major concern. We don't think that transmission is likely during this period unless people are giving blood. And so I think that's something to be mindful of. So conclusions from her talk on the syndrome: incident HIV infections, at least in HPTN 083 and 084, were rare with people who had timely injections, but integrase resistance was detected in 10 out of 18 cases where CAB was administered within 6 months of the first HIV positive visit, so that was determined retrospectively. Interestingly, no INSTI resistance occurred when that first HIV positive visit was over 6 months from the last CAB dose. And so that took me a bit to kind of think about. Initially when I heard it, it seemed like it was counterintuitive, but I think probably makes sense because they're sort of farther out from their last dose and potentially the levels are low enough maybe where the resistance is not happening. Hard to say. Again, a crucial component of monitoring for people on CAB-LA is sensitive viral loads, and whether it can be ultra-sensitive, we don't really know. And then talking about the LEVI syndrome and whether this can occur with other long-acting agents, it remains to be seen. So just ending for CAB with a little rapid fire. So more updates from HPTN 083. So this was the study of CAB-LA versus oral PrEP in in MSM and transgender women. But Hyman Scott looked at particular analysis among Black MSM and transgender women and found there was a dramatic incidence reduction for HIV in that group. So over, nearly 80% or so. And when they looked at oral PrEP adherence in this group, it was pretty low. So 65% in the Black participants versus 81% in the non-Black participants. And then Meredith Clement further looked at people who were in the open label extension portion of the study where they were offered either to continue on CAB-LA or oral PrEP. They can kind of take their choice. And remarkably, 96% of people chose CAB-LA over oral PrEP. And so that's pretty impressive to me. Sybil Hosek in HPTN 084, the study that was in African cis adolescents who were assigned female at birth, she noted that there was high interest in adherence in African adolescent girls and young women who were less than 18. They found that the injections were safe and tolerable, no incident HIV infections, and that 92% of people chose CAB-LA when it went to the open label portion. Dr. Solomon mentioned a lot of things that we still don't know, and I think none of this is maybe new to you all, but we do need trials in people who inject drugs. We need to know a little bit more data about whether there are drug interactions with things like buprenorphine, other substances of misuse. There's a lot of talk about xylazine being in drugs now, how would that interact? Could this be used in people who are released from jails or prison or who are otherwise unstably housed? And I think that's an area of active research right now. What will really happen when people discontinue due to injection site reactions? And then, there is all this talk about sort of oral ART needed to cover the PK tail, but how does that work if it's someone who didn't want oral meds to begin with? So I think that's a big question that we don't know the answer to and should be studied. Okay, so moving on to oral PrEP in women. So Jeannie Marazzo presented data from a study that their group did where they pooled together 11 demonstration projects across the world. You can see the countries listed there, including around 6,300 cis women, and looking at efficacy for FTDF in terms of HIV incidence. So this was performed basically between November 2012 to December 2020. And they looked at objective measures of adherence based on sort of pill counts and dried blood spot samples, and then subjective adherence through a variety of measures. And what I found was, striking, but maybe not surprising, is when we looked at objective data and subjective data for the women and what they reported, it was quite discordant. So you can see here on the right panel, the blue is basically, I took more pills per week than not. And you can see people reported 7 tablets a week pretty consistently early on. But then when you compared that with objective data from the dried blood samples, it was pretty different. So adherence declined over time, but we know that people do tend to over-report their use. And so they basically did this kind of cool method where they put people into groups based on their trajectory in terms of their adherence and sort of looked at what the HIV incidence was in each of these groups. So over 96 weeks, they found 4 patterns of adherence, consistently daily, which is over 7 tabs a week, consistently high as 4 to 6 a week, high but declining is 2 to 3 tabs a week, and consistently low is less than 2 tabs a week. And so when they looked at HIV incidence in these groups, you can see here that for consistent daily use, not surprising, 0 infections in that group. People who used it consistently high, which is 4 to 6 tabs a week, there was only 1 infection, which is an incidence of 0.13 per 100 person years. So the point here was, I think that's pretty close to 0 and maybe lower than what people suspected for cis women. And then not surprisingly, when adherence is low, there were more infections, so the HIV incidence was quite a bit higher. So what she concluded from this was, even with low HIV incidence, better adherence is associated with lower risk. And given the fact that there is inconsistent adherence to oral PrEP, long-acting agents may be preferred for this population. And we talked about how cis women really did prefer that in the studies when open label was extended to them. And then FTDF, I think we've talked about a lot how cis MSM, we have data to suggest potentially that 4 tablets a week may be enough to provide protection. But she kind of went on a limb here and said, this evidence actually suggests that this may be the case for cis women as well. So we wouldn't advertise that, and we certainly want people to do their best to try to take 7 tablets a week, but maybe if they only hit 4, the HIV incidence is not that different compared to when they're taking 7. So could this be a paradigm shift for how we counsel people in terms of time to protection and how many doses they need to take? I'm not answering that. I think that's an open question, but it's really interesting to think about. Okay, so moving on to kind of what I thought was like new age, hot, and really interesting topics. So first, to talk about these ultra long-acting in-situ forming implants with cabotegravir. So essentially, this is when cabotegravir is injected into the sub-Q space. There's a sort of phase inversion that happens. It sounded very like Star Trek to me when she was explaining it, which causes the substance to harden, and it turns into an implant that stays in place in the body and can later be removed if the user wants to end treatment. And so it's a biodegradable polymer, and if it doesn't get removed, it will sort of degrade into the body and go away over time. They suspect, that would take around a year or so. So they tested this in female macaques and mice, and they were able to prove that as long as the implant was in place, again, they saw levels that were 4 times above what they think is necessary for therapeutic concentrations. And then you can see in this graph here on the left, when they removed the implant, there was a sharp drop off in the levels of cabotegravir. However, there was still a tail, and so 25% of the drug was left and 15% of the polymer was left. And you can see when they added in a radio-opaque substance, you can kind of look over time up to 210 days, you can still see the implant is there and hasn't moved. So they think this is, promising potentially for being co-formulated with like contraceptive agents or other things. So a lot of promise for a sub-Q option. Another thing that I found super interesting is an on-demand insert that can be used for PEP or PrEP. So this is a fast-dissolving product that contains TAF and elvitegravir that showed efficacy in non-human primates when they were challenged with simian HIV. So either using one vaginal or 2 rectal inserts. And so in this study, they looked at the efficacy in animals and kind of PK/PD data after either using 1 or 2 rectal inserts, in humans, and basically reported that there was just some mild erythema around the anus in one person. They got really good rectal plasma levels that they think were good enough to kind of provide protection. And they proved that elvitegravir levels were present 2 to 24 hours later, and tenofovir was sustained up to 3 days. And the levels that they saw for tenofovir diphosphate, which is kind of the metabolite, exceeded those compared to steady state when people were taking oral FTDF. So this is just a graph kind of showing the levels that they got for 1 and 2 inserts over time in rectal fluid and rectal tissue. So the authors, concluded from this that it was safe and well tolerated, that they got high concentrations in all the compartments that they tested. And so, this has promise for PEP, essentially. If someone could kind of put this in after they had an exposure, that they could achieve levels that were protective there in that body compartment. Another author looked at this as well in a non-human primate model as PEP. And you can see sort of when they put the insert in at 4 hours after an exposure, 100% of the animals remained protected. At 8 hours, 94%. At 24 hours, 77%. And then, of course, in placebo, all of the animals acquired SHIV, so did not work, of course. I think this is promising and kind of cool, giving people options for ways to sort of prevent HIV. So lenacapavir, you've all heard about, and then a parent compound that the pharmaceutical company is making for PrEP showed at a sub-Q preparation that this fully protected macaques after SHIV challenge 7 weeks after they got a sub-Q administration. So the infection rate you can see there was 63% in the untreated versus 27% in the treated, as long as target levels were reached. And so they noted that they have a Purpose 1 and a Purpose 2 trial that are ongoing. These are randomized controlled trials to look at this strategy for PrEP. And they're soon to start the Purpose 3 and 4 trials, which will be done in Black women and people who inject drugs, respectively, which I think is great that they're sort of doing this up front instead of waiting for it years down the line to kind of look in these populations. And this is all based on data that lenacapavir protected macaques who were challenged with IV SHIV. And so that's kind of the basis for looking at this in people who inject drugs. So right now it's being given in the abdomen, but they say, this could be considered in other places, and they feel like it would be a discrete option, just has a little palpable nodule that you could feel that goes away within about a week. Okay, so biodegradable implants, also kind of cool. So these are female pigtail macaques that got these implants kind of put in, almost like a contraceptive device. And they showed 5 of 6 animals had good plasma islatravir levels and were protected as long as that level was therapeutic. There was one breakthrough infection associated with low plasma levels at week 28, and that was 6 weeks after they were challenged with HIV. So pretty good protection. The author said, this takes about 2 years to biodegrade, and they think the islatravir levels take about 2 weeks to leave the body. So there's not a significant PK tail, but it is something to be aware of. There were minimal site reactions, just a little bit of erythema in 1 out of the 12 animals that they tested. And then lastly, refillable islatravir implants, which I thought were really fascinating. So about the size of a penny, can kind of go, and they put these in the back on the animal so that they couldn't reach behind them and pull it out, but go in a different place in a human that would be able to leach islatravir slowly over time. So keeping levels kind of high for up to 20 months potentially. And when they put these implants into the animals, 100% of infections were prevented when they did rectal and vaginal HIV challenges, and they did not see any significant change in renal function, hepatic function, or the absolute lymphocyte count. I will end here with just what else I found interesting because I couldn't edit down. So there was an abstract about feminizing hormone use in FTAF for PrEP, and they found that even though the FTC and tenofovir levels were decreased a little bit, that there were no clinically significant drug-drug interactions. So I think for trans women who are on feminizing hormones, that's good to know. Another abstract looked at islatravir that was given every month for PrEP, and a lot of concern about obviously the lymphocyte counts. That showed that in women that there was a 20% decrease in the absolute lymphocyte count, and in MSM and transgender women 7.5%. But when people switched to oral TDF or FTAF, those counts rebounded within a year to the same level as controls. So seems to be dose dependent and also time dependent. If you go off the drug, it improves. There was an abstract about urine point of care testing for tenofovir that had really good positive predictive value compared to dried blood spots for people that may need to use that clinically. Another abstract that talked about meth use, not only in the person on PrEP, but in their partner, how that had really significant impact on people's ability to engage with PrEP care. So you can see the odds ratios were pretty high there, 3 times as likely to disengage if you and your partner both use meth. And then the last thing that I thought was fascinating was there was a scientist that presented about an association between lactobacilli and this group of bacteria called Lactobacillus that apparently metabolize tryptophan, and in HIV cell culture, essentially, these bacteria can inhibit HIV almost as well as ART. So I don't know what we would do with that information, but I found it was fascinating. So that is the end.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.